So I think we can start with this session. It's the ESSKA Orbit session, and it's a pleasure to be here. And thank you for the organizers for inviting us. It's a great conference, very well organized. And actually, my colleague, Laura Di Girolamo, she's a world expert in orthobiologics. One of the top researchers in the field is going to present the first part of the consensus. And one thing you should know about Laura, if you don't know her from her scientific work and publications, some of you may recognize her because she has a very strong addiction to Romanian dancing, as you can see here. So it's my pleasure to invite my colleague, Laura, please.
Thank you, Leo, for the nice introduction. And yes, it's true, actually, I had lots of fun last night, so thank you very much for inviting us and for giving us the possibility to share your fantastic folklore. So, let me see. Okay. First of all, as Leo said, thanks to Sorot for giving us the possibility to share the results of this consensus project, which was conducted 6 months ago, more or less, and presented already in Paris, the ESSKA Congress, but for who was not there, it's a pleasure today to show the results we got with this consensus. And first of all, on behalf of the ESSKA board, I will bring the regards of the board to the Sorot Society and the Sorot members. So, this is indeed a big project under the umbrella of the Orbit initiative, which I will describe soon in the next slides. And actually, for the first part of the orthobiologic consensus, we actually focus on the blood-derived products, and in particular to all the PRP family. These are our disclosure. So, it's clear, I think everyone knows that the fields of orthobiologics, the interest for the field of orthobiologics is increasing in almost all the countries, of course with differences among countries and in Europe, but also at worldwide level. However, due to different reasons, including the variability in indications, the huge market of available products, as well as the consequently different administration protocols, the results of this treatment are not always consistent. And moreover, if this is not enough, also the regulatory issues are complicated, not very clear, different among countries again, and they imply, of course, reimbursement consideration and commercial challenges. And all of this risks to devalue the potential and the use of these treatments, and this would be a shame because actually these treatments work and can be really a very powerful tool in your hands to treat your patients. So in this context, as ESSKA, as the European largest association of musculoskeletal specialists for arthroscopy and sports traumatology, felt he had the responsibility to advance the quality of care in orthobiologics in a fully transparent and scientific manner. And therefore, roughly 3 years ago, Leo and I have been asked by the ESSKA board to run the orthobiologic initiative, which we acronymize as ORBIT. And the aim of this initiative was to establish and assemble an international collaboration to create a common language and a uniform and responsible voice in the field of orthobiologics. These are our logo. And our mission actually are many, actually we have different missions, but the most important are to promote the responsible use of orthobiologics in the daily clinical practice, to address the regulatory issue across Europe by improving the standards and defining clear indication, And at the end of the day, we want, with this consensus project, assist clinicians in decision-making by providing a specific recommendation. And indeed, we run this ESSKA formal consensus on blood-derived products in knee osteoarthritis. The consensus aim is not to provide information about the specific technique of commercial system, because as you know, it's a jungle of commercial systems, so that would be probably impossible or even non-effective, but rather to provide general recommendation about the use of blood-derived products for knee osteoarthritis. To be precise, we should always talk about blood-derived products because indeed it's a family of products, but for sake of simplicity, we decided to use the term PRP, which stands for platelet-rich plasma, because this is the most common term that everyone uses to refer to this wide product category. So in the document of the ESSKA project, as well as in the slides today, you will always find PRP, but this is used to refer to any autologous blood-derived product based on platelet concentration by minimal blood manipulation. So a few words about the method we use. So what is a formal ESSKA consensus? So the consensus is composed by 4 independent groups. There's a coordination of the consensus where are 2 chairs and an ESSKA consensus advisor who coordinate all the consensus projects for ESSKA, so it's very expert. There's a steering committee, in our case composed by 14 members, experts of course in the field, which decide the subject of the consensus and actually prepare the question and answer. And some of this group, the people of this group also compose the literature group. We perform the bibliographic search and summarize the main findings. Then there was a rating group, in our case composed by 22 members, which evaluate the draft prepared by the steering group. And after a round of evaluation, there's a joint meeting between the 2 groups to prepare the final document, which is sent to the peer review group, which in our case is composed by 15 members, selected among the ESSKA National Affiliated Society and representative of the European countries. And of course, SRATS is also one of these societies, so we had in the peer review group also Romanian members. And the goal of this group was to assess the geographic adaptation of the proposed statement. So just this is a slide to summarize the process. So there's a steering committee group, which prepare indeed identify the topic and prepare the questions and the answer, and develop a first draft, which is sent to the rating group, which of course can evaluate with a specific score system each statements, also providing comments or suggestions. And the first draft is then transformed into a second draft after the 2 rounds of rating group. And there's a joint meeting between the steering and the rating group to discuss the second draft, which is then sent to the peer review group for the geographic adaptability. And after the comments coming from the peer review group, we had the final text, which is now uploaded on the ESSKA website under the section projects. So in each statement we are going to present this morning, you will find 2 different grading systems. One is about the scientific level, and so for each statement you will see a grade A, B, C, or D according to the quality of the scientific level, where D, of course, is the lowest, but still when we miss literature, expert opinion is also very relevant and important. And also an agreement score, which is given by the rating group, where 1 is the minimum agreement and 9 is the maximum agreement. So in this specific consensus, Leo and I had the pleasure to be the chairperson, and we worked together with the scientific ESSKA advisor, which is Philippe Beaufils from France. And the steering committee is composed by the people you can read there, and in particular, let me thank Rodica, because she was great in this process. She participated really actively, so thank you, Rodica. And thank you also for facilitating our presence here today. This is the picture. Unfortunately, we worked during the pandemic, so this was the way we met, but we met many, many, many times, so each of us was really committed to this project. And this is the rating group, and again, it involves one of your colleagues, Stefan Mogos. And as I said, the peer review group, which is 50 elected members from the 20 European countries, specifically the affiliated ESSKA societies. So the document is structured into 3 sections. The first section is about the PRP rationale and indication. The second section is about the PRP preparation and characterization. And the third one is about PRP protocol. So I will describe the first section, and then Leo will present to you the section number 2 and 3. So we start from question number 1, which is probably the hottest question of the entire consensus, which is if indeed we have current clinical evidence to support the use of PRP for knee osteoarthritis. And actually, after carefully searching to the literature, level 1 and 2 clinical studies, as well as meta-analysis and systematic review, which summarize the findings of this study, support the safety and the clinical benefit for knee osteoarthritis, both in comparison to placebo and also in comparison to control treatments such as corticosteroid and hyaluronic acid, and I will go deeper into these 2 comparators later. And so the consensus group concluded that there is enough preclinical and clinical evidence to support the use of PRP in knee OA, with a very high agreement of the rating group, which is 8. I reminded you that the highest is 9, and with a grade A, so high scientific level. So yes, there's current clinical evidence to support the use of PRP in knee OA. Then we went a little bit deeper inside the indication of knee OA, and we wonder for which degrees of knee OA is PRP best indicated. And according to the literature, again, a grade A, so high scientific level, the clinical evidence has showed the effectiveness of PRP in mild and moderate cases of knee OA. So the consensus group concluded that PRP can be indicated mainly in these patients. However, I think it's in your daily practice, you have patients with worse knee osteoarthritis, maybe KL4. And so what the literature say about the KL4? Actually, the literature is not very precise on this kind of patients. And however, given the findings we have and also the expert opinions, the consensus group agrees that PRP treatment could be also considered in selected severe knee osteoarthritis, especially if these patients decline or are not suitable for other for the surgery, major surgery due to other comorbidities. However, it is very important that physicians tell the patients that the expectation should be lower than the expectation in a patient with mild or moderate knee osteoarthritis. Again, more deeper, for what age range is PRP recommended? And when we search literature for this topic, we, of course, took into consideration that the efficacy of orthobiologics, including PRP, is multifactorial. So probably age, of course, is important, but it's not the only criteria we should take into consideration when indicating a PRP procedure. The majority of the study includes patients with a mean age between 55 and 65 years of age. However, the consensus group agrees that a specific age range cannot be recommended, although based on the clinical findings, the consensus group recognized that there is evidence of reduced response in older patients. And this is, however, an expert opinion, but with a high degree of agreement by the rating group. Then we ask if PRP should be used during the inflammatory phase when joint effusion is present. And of course, the preclinical and clinical study demonstrate an anti-inflammatory, very strong anti-inflammatory properties of PRP, which could support the rationale for its use during the inflammatory phase. However, while evidence is lacking with regards to the optimal timing for PRP injection, when effusion is present, the consensus group recognized that when present, effusion aspiration should be performed. First of all, because it's likely beneficial in pain improvement and relieving functional limitation, but also to avoid the dilution of the PRP following injection. On the other side, how many cycles of PRP should be performed in a patient? Is a repeated cycle of PRP recommended following a previous successful PRP treatment upon the reemergence of symptoms? And actually, the current evidence regarding the repeated cycle is limited. And so as expert opinion, we actually agreed that an additional cycle could be considered upon the reemergence of symptoms if patients benefited by the previous cycle of PRP injection. On the other side, what if our patient is asymptomatic? So not upon the reemergence of symptoms, but if the patient has no symptoms, what should we do? Should we use PRP as a preventive treatment? Actually, the literature does not report enough data addressing this question, and therefore it cannot be stated that the application in asymptomatic osteoarthritis prevents its progression. We know from preclinical study there's PRP as a counterprotective role, so theoretically yes. However, the lack of sufficient clinical data on humans brings the consensus group to not advocate the use of PRP in asymptomatic early knee osteoarthritis. And as promised, what about the comparison of PRP with corticosteroids? So we all know that corticosteroids are associated with detrimental effect on chondrocytes, which can lead also to an acceleration of cartilage degeneration, especially if this treatment is repeated over time. The literature clearly show, with a grade A, so high scientific level, that PRP injection have a longer effect in comparison to the shorter term effect of corticosteroid injection, and also they seem to provide a safer use profile with less potential related complication. So the consensus group considers PRP injection to be a safer and more effective treatment option with longer-term clinical improvement compared to corticosteroid injection, with a very high agreement by the rating group. Similarly, is PRP a clinically better injectable option than hyaluronic acid for the treatment of knee OA? Again, the literature supports this statement, actually. So based on current available evidence, the consensus group supports the use of PRP over hyaluronic acid for knee osteoarthritis due to an overall clinical improvement and expected longer-lasting effects. However, we acknowledge that in both types of products, so both for PRP and hyaluronic acid, we have different products. So it's a general statement, but of course we need to, in your practice, you should really make sure that you are using the most performing PRP for your patient or the most performing hyaluronic acid for your patient. But overall, the literature supports the superiority of PRP over hyaluronic acid. And last but not least, because to me as a scientist is very important, we always talk about the power of injectable orthobiologic as disease-modifying treatment in the pathologies we treat, in this case in knee osteoarthritis. So few clinical studies actually have suggested or have addressed the disease-modifying potential of PRP, because of course it's difficult to assess this in our patients. So because we don't have sufficient literature to make a recommendation, the consensus group recognized that the current clinical evidence regarding the disease-modifying effect of PRP in knee osteoarthritis in human is insufficient. However, this is very important because preclinical animal studies suggest disease-modifying effect. And still under the Orbit umbrella, we are conducting 4 systematic reviews assessing the disease-modifying effect of the orthobiologics. This one is about the blood-derived injectables, so the topic of this morning. And in this systematic review involving 44 articles and a total of 1,200 animals, we found out that 80% of the papers reported clinical effects, clinical benefit from PRP, and 68% of these papers also report disease-modifying effect, especially at cartilage, synovium, and biomarkers level. And in particular, in terms of cartilage, it has been demonstrated an attenuation of damage progression, reported by the improvement in histology and immunohistochemistry markers, a decrease of inflammation of synovium, and also positive changes in osteoarthritis inflammation biomarkers. So now I'll ask my wonderful co-chair Lear to go on with the section number 2, which is about the PRP preparation and characterization. And thank you very much for listening.
Okay, so first of all, say a few words. E un mare plăcere să fie aici. Pentru mine e special pentru că familia mea sunt originat din România. Atunci e special pentru mine. Mulțumesc mult pentru invitație. So, as you will see, the different sections in the consensus are structured. It goes from a broader perspective and going deeper and deeper and narrower into different procedures. So the second section we focused on was PRP preparation characterization. One of the questions we addressed is which PRP is preferred. It's one of the biggest questions. Should we have white blood cells in the preparation or not? And actually, we don't have a good enough answer. As you can see, we have an abundance of literature. However, it's inconclusive. And there's a wide variety in the different studies. And I'm going to address this issue in just a bit. But the consensus group currently does not support one type of PRP over the other and considers both leukocyte-poor and leukocyte-rich PRP valid options for management of knee osteoarthritis when PRP is considered. So we have studies showing this works, nothing conclusive about one being better than the other. There are a few publications showing maybe a tendency for leukocyte-poor, but nothing conclusive. So we can't be very decisive at this moment. What is the recommended platelet number or concentration range for PRP injections in knee osteoarthritis? Well, again, there is large variety, and actually the different studies, and we have many RCTs. We currently have 37 RCTs looking at the use of PRP for knee osteoarthritis, but only a minority actually analyze and report the different baseline concentrations of the patients, the contents of the PRP, and so on. So again, and you have to remember that the effect of PRP is not just based on one factor. You're going to hear it again and again. It's multifactorial. So it's not just the concentration. And there are obviously numerous growth factors released, and they play an important role. And there is no doubt that the platelets are the main player in PRP products. However, we cannot at this point conclude the optimal characterization of PRP for knee osteoarthritis. It's complex, includes many variables, and so an optimal range right now cannot be defined. And this is one of the issues. This is a systematic review published not too long ago, looking at 105 studies, and only 10% provided comprehensive reporting, including a clear description of the preparation protocol and quantitative metrics of the composition of the final PRP product. But on the other hand, why are we so eager and we criticize this field of orthobiologics? When we do ACL surgery, for instance, do we ask the surgeons to compare and to analyze the tenocyte content of each tendon that we harvest? Or if we use allograft, are allografts from a 20-year-old or a 30-year-old, are they the same? So why are we so critical when it comes to orthobiologics? Something to think about, because we have more evidence on orthobiologics than when it comes to, for instance, ACL, in terms of like RCTs and high-level studies. So it's just a thought. So we definitely need better reporting, but should we be that critical? And when it comes to PRP preparations, yes, we want our different studies, future studies, to be better, and perhaps we should use this in our practice. But what should we measure in terms of quality control? So we obviously we can't measure everything. We need to be practical. But our group suggested, and this is a grade D statement, suggested recording baseline whole blood cellular and platelet composition, as well as of the produced PRP preparation as a minimum, would improve understanding the efficacy of PRP for NEOA, and should be recommended as quality control routinely in clinical setups in the future. So these are the things we recommend measuring as a minimum. And when you measure these, you have different classification systems. We're not saying one is better than the other. This is just the most recent one published, and many of our Orbit group were participating in that. And as you can see, it's very simple. It puts down basal platelet concentration in the blood, in PRP, the presence of red blood cells, white blood cells, whether was there external activation or calcium activation. So it's pretty simple, but you just need to record it. What about volume? So we said it's multifactorial concentration. What about volume? And again, the literature is quite variable. There's large variability. And different studies looked at ranges between 2 and 12 mLs. This is a huge difference. So we cannot currently recommend a specific volume or a narrow volume range. However, we do suggest that knee size should be taken into consideration. When you have a very small, perhaps old lady compared to a huge handball or basketball player, there's probably a big difference in terms of the knee volume. And when you think about PRP affecting the entire knee environment, and also the synovium, perhaps 2-3 mLs in a large knee wouldn't have the same effect as it would in a small knee. What about synergistic effects between PRP and hyaluronic acid? While current preclinical and clinical literature suggests some potential benefits, and actually there are some high-level studies, but not enough to say, okay, this is better than just using, for instance, PRP. There is some promising evidence, but at this point, the consensus group recognizes that more data is required before strongly recommending the combination of PRP and HA over PRP alone. However, there are some promising studies, and it's not a mistake to do it. What about PRP and cell-based therapy? Is there a synergistic effect? And again, preclinical and clinical literature suggests some potential benefits of combining these products. With the majority of studies focusing on culture-expanded cells, evidence is still lacking with regards to clear benefits of using these products in combination over using them on their own. So at this point, we do not suggest the combination of PRP and cell-based therapy over PRP or cell-based therapy alone. However, the potential is there, definitely. So again, not a mistake to do so. So the third section focused on protocol aspects. For instance, how many injections are recommended of PRP are recommended for the treatment of knee osteoarthritis? And the literature is not conclusive, and there's, again, large variability. However, the majority of studies report that protocols with more than one injection provide better clinical improvement, at least with mild to moderate osteoarthritis. And again, we realize that it's multifactorial, and factors like injection volume, as we talked about, platelet concentration, largely differ between different PRP products. However, based on literature and our experience, we recommend a range of between 2 and 4 injections, definitely more than 1 injection. Now, when we're using a PRP treatment protocol with more than 1 injections, what should be the intervals between injections? In the literature, again, there's variability with intervals ranging from 1 to 4 weeks being reported. But when you take into consideration that the main period of released growth factor actively takes place within the first 3 weeks from injection. The consensus group suggests interval ranges between 1 and 3 weeks are more appropriate. What about syringe size? Do they matter for both injecting and blood harvesting? So current evidence does not suggest that needle size matter, and we therefore recommend that it should not matter, neither for injection or for blood collection of PRP preparation. If you think about it, plastic surgeons, dermatologists, they use very small diameter of needles for injections. So definitely the ones that we use for knee are larger than that. What about for blood harvesting? Again, we do not think it matters for blood harvesting, blood collection. However, one thing we felt it was important to say that caution should be applied as to the flow rate during blood aspiration when using large-sized syringes, especially in manual techniques, to avoid blood hemolysis. What about NSAIDs use around PRP treatment? There are several studies showing that the effect of antiplatelet and NSAIDs medications can decrease growth factor and mitogenesis. And therefore, while the literature is not conclusive, we prefer to be more cautious. In answering the question of are non-steroidal or are NSAIDs allowed around PRP use, we do not recommend, we recommend avoiding the use of NSAIDs for at least 2 weeks prior to PRP administration because of its potential effects on platelets and in vivo growth factor release. And when it comes to following the injection, again, because it may still affect growth factor release even after the injection, we recommended avoiding NSAIDs for at least the first week following injections. And for pain management, you can use other medications like paracetamol, Dipuron, Tramadol, and so on. What about antibiotics? Are they recommended around PRP use? Well, injecting PRP is like injecting, any other thing, other products that you use for knee injections, whether it's corticosteroids, hyaluronic acid, and I'm sure most of you don't use antibiotics when you do it. And clinical evidence definitely doesn't support it, so our group did not recommend the use of antibiotics around PRP administration. And in fact, there are some studies showing that PRP have some antimicrobial effects. So when you compare it to other injectable products, it's likely to be safer. What about food? Is fasting recommended before? Because we know different foods might affect our blood and platelet concentration. So data regarding the direct impact of fasting on PRP is lacking. However, there is some evidence on the effect of various foods, especially high-fat and high cholesterol foods on platelet behavior, and therefore we recommend to avoid high-fat foods for at least 24 hours prior to blood harvesting. What about other behavioral recommendations? Alcohol, for instance, there's evidence showing that it might affect platelet behavior, and we recommend avoiding it for at least 48 hours prior to PRP preparation. And again, not conclusive, but it's a fair suggestion. What about, we have many patients who come to our clinics and they've had a previous corticosteroid injection, maybe recently, and one that didn't work, and this is why they're coming in again. Can we actually combine corticosteroids with PRP? Well, Laura mentioned the chondrotoxic effects of steroids, and obviously there's not a synergistic effect between steroids and PRP. And our group recommended avoiding using PRP in close proximity to corticosteroids. And we recommend it would be safe to have a minimum interval of at least 6 weeks from a recent corticosteroid injection. And this is a grade D expert opinion. The literature is very scarce on this. What about local anesthetics use? Many patients ask for local anesthetics. They don't like, the feeling of the needle going into the joint. However, this is an issue. There are no high-level clinical studies regarding this. However, we know that local anesthetics interfere with platelet integrity and functionality, as well as diminish the positive effects of PRP on cell proliferation. Therefore, we do not recommend using intra-articular local anesthetics when injecting PRP. The PRP product is quite expensive, so we don't want to risk ruining it with local anesthetics. However, we do agree that local anesthetics can be used subcutaneously without penetrating the capsule. For some patients, it's another stab. However, if they prefer it, then you can do it. So let's talk about some of the strengths and limitations of our consensus. Obviously, we didn't cover all the questions here in this presentation. There are some other questions we answered, and you can read a full document on the ESSKA website. And one of the strengths of this consensus, especially done through ESSKA and using the ESSKA methodology, is it's a pan-European project. It's the first European experience in this field. It's a strictly independent process with a large number of participants and involves a large number of countries in Europe. It's based, as Laura mentioned, both on scientific evidence, but also on clinical expertise. But definitely it has several limitations. As you've seen, some topics have low scientific evidence, so obviously the quality of the available studies limits the quality of the consensus. Consensus is not focused on the ideal candidate for this treatment, and therefore we're currently running another procedure called a RAN procedure to identify the ideal patient, ideal scenarios where PRP would work best for knee osteoarthritis, and we'll publish this in the next Congress in Milan. You also need to remember that a consensus is actually a snapshot of current knowledge, and evidence obviously can continue to evolve constantly, especially in this field of orthobiologics. There are obviously practical constraints in daily practice which are not always reflected in a consensus, whether it's cost issue. A consensus does not take into consideration cost issues. We're talking about, what's the best treatment. And practice may vary even in the same country. What you can do, time limitations, cost limitations, and so on. Also, we need to remember that the arthritic knee is complex, and treatment today is taking more of an individualized direction. So what suits one person might not necessarily suit another person. So looking at a consensus, it's rather a framework than strict guidelines. It's there to help you and provide some guidance and recommendations, and not strict guidelines. Quality of available studies, as I mentioned earlier, is also an issue. And you also need to consider what is scientific evidence. Because, there are 37 randomized controlled trials, but as good as they may be, they have their biases and weaknesses, of course, whether it's patient selection, analyzing it as intention to treat or as treated. Obviously, we can play with statistics every direction we want to, and we know that, so there are biases, and of course, conclusions can be drawn in different directions and based on the statistical analysis. So RCTs, they're good, but still they have their limitations. And we also have practical considerations and constraints. Is a consensus the only factor which may influence the decision of the surgeon and the patient? Definitely no. Healthcare systems are different among European countries. And, it was in an earlier session today where it was evident, what's available here in Romania might not be available in other countries and vice versa. So we need to take that into consideration, and they definitely influence the daily practice and are not always in line with scientific data, you know, whether public system, private system, the way they're reimbursed, and so on. But one of the things that we did with the methodology, and it's part of the ESSKA methodology, is running a peer review step, which is the final step. And basically, it tests the geographical adaptability of the recommendations to see how it fits in different countries and get comments from the affiliated societies. And in the current consensus, the peer review group evaluated the consensus very positively in terms of geographical adaptability and acceptance. So this is a very, very important step. So to conclude, PRP is a valid treatment option for knee osteoarthritis, mainly for mild to moderate grades of OA. When considering injection treatment for knee OA, PRP could be considered as a first-line injectable treatment option. So you don't need to do corticosteroids first, hyaluronic acid second, then PRP. You could use it as a first-line treatment. PRP has been shown to have clinical superiority over other available injectable treatment options, such as corticosteroids, hyaluronic acid. Although it's important to note there is currently great variability in both PRP and HA products, and these keep evolving all the time. You might have new products, for instance, HA products, which are better than current ones. This is an algorithm that basically summarizing, you know, when you have mild to moderate, you can opt for PRP. Same for severe OA in selected patients. If, basically, more than one injection is better, 2 to 4 is recommended with 1 to 3 weeks interval. If symptoms reemerge, then you can use another cycle of PRP. You can read the full text of the consensus on the ESSKA website. We also have this brochure that we prepared for the Paris Congress. It's actually very useful. A lot of people request it from ESSKA. You can print it, you can put it in your clinics, and it summarizes the consensus. And we're actually currently working, as I mentioned, on the RAND procedure to identify the ideal patients, but also on part 2 of the consensus, which focuses on cell-based therapies for knee osteoarthritis, and we'll present all that in Milan in 2024. And one last thing, I used to be a professional athlete, handball player. Handball is pretty big in Romania. I'm not doing this to show off, because when I retired, I became a commentator in the Israeli TV. And I also treat a lot of athletes, football players, handball players. And one of my patients is the goalkeeper of the net. He plays in the top league in France, but he's the goalkeeper for the national team. And I was invited to commentate on this game, international match. So it's weird. I'm also the doctor of many of the players, but I'm also the commentator. He has already, he's 27, 28 years old, had a meniscectomy, lateral meniscectomy. His lateral compartment looks terrible, and he's been treated with PRP injections. If you can press play. I'm sure you'll all understand what he's saying.
נבוא על הצד טוב ביותר, בטוח. דן טפר, בונסואר, כל הכבוד, או שפו כמו שאומרים אצלכם בליגה. תודה רבה, והדוקטור לידך זה ה-PRP עובד. ביי ביי, תודה רבה.
So as you can see, that's more evidence, maybe sometimes better than RCTs. No, not really, but yeah, you always like it when your patients are happy. So thank you very much.
Thank you, Lear. Thank you so much. And now we are open to the discussion. Any question is welcome from the floor. Yes, please.
Do you have any recommendation? You said that you're not against or you do not advise against PRP and
hyaluronic acid both together.
Yeah.
Do you have any suggestion about the time frame between PRP and hyaluronic acid, if considered to do both therapies?
Yeah, so in my practice, I use them together at the same time. Sorry. In my practice, I use them together at the same time. If you're thinking about the potential synergistic effect, you want it to occur, you know, at the same. So you can use it in one injection or 3 injections, but I use them all, like both together at the same time. And then you can ask some other questions. So what do you inject first? How do you inject it? So I inject PRP first. And I also, depends on the PRP I'm using, I use a variety. So I discard the PPP, so it's the top fraction, but then I use the middle fraction and I mix it with the hyaluronic acid. Because if you think about it, hyaluronic acid is used in orthopedics as a carrier. So this is what I'm trying to gain. So having both the hyaluronic acid, but keep releasing the PRP perhaps for a bit longer. So this is how I do it. So I mix the middle fraction with the hyaluronic acid. I inject the PRP first and then the HA mixture.
All right, thank you very much.
Yeah, and there are also available products in the market which already allow you to combine the PRP and hyaluronic acid with the same device, actually. So if you believe in this kind of combination, which would be providing biomechanical supply and biological supply, then you can also use this kind of device, or of course you can prepare the 2 things separately and then put together, yes. You're welcome. Any other curiosity? Yes, please.
There are several papers regarding the technique used, and they are like Regenex or providing, you say about the volume I'm speaking, and they do, you have a pathology for the meniscus and other ultrasonic guidance, they do injections with the PRP there and put the some inside the knee and some inside close to the synovium. Do you feel there is a need for such an personalized approach, as you mentioned, with a little more?
Yeah. So, first of all, you know, Regenex are very controversial in what they do.
I'm not speaking about the brand,
No.
about
So,
the technique of injection.
I think that first of all, meniscus is not part of this consensus. I think Rudika is going to talk about this in the next session. I agree, the concept. So if you think about PRP affecting the entire joint environment, okay, the synovium, okay, there's evidence that it affects the synoviocytes to secrete more and generate more hyaluronic acid, and other aspects of it. Yeah, ideally it could make sense to inject it even into to the synovium, to the capsule, but it's more difficult and more painful for the patient. So you need to also consider what's practical in your practice, in your clinic, and I think it works well when just injecting into the joint. It's not the topic of this session, but for meniscal tears, if you're treating it conservatively, yes, I think it makes sense to inject it to the meniscal capsular junction. You can do it with ultrasound guidance. I mean, trephination, isn't it the same, doing it from the inside, right? So we're doing it from the outside and causing some bleeding and injecting orthobiologics, so it makes a lot of sense. I wouldn't inject large volumes into the tear because it can expand the tear, so just small volumes. There's actually, it hasn't been published, but one of our colleagues from the steering group, Mikel Sanchez, who's published a lot on this topic, has done some cadaveric studies on injecting into the meniscus and showing that, so he colored the PRP with methylene blue, showing it distributes quite nicely in the meniscus, although it's like a more solid tissue. So that's interesting, but yeah, it makes sense. Yeah.
Yeah, and if I may, going back to the volume issue, actually, if you remember, Leo showed that we couldn't identify a narrow range, and we had actually to include between 2 and 12 ml, because this is what the current medical devices allow us to produce. But volume is also a false friend, so injecting 12 ml, it doesn't mean that you have a better response than 2 ml, because we are talking about concentrating platelets. And so if you start from a similar volume of total blood, whole blood, and then you get your technique to prepare the PRP, of course, the lower the volume, the highest, the lowest the volume, the higher the platelet concentration. So it of course depends on the techniques you are going to use. And I think our statement on the volume issue has to be taken as a guidance, just in case you have a higher volume of the final product and you have to decide how much you want to inject in your patient. But that doesn't mean that 2 ml is worse or better than 12 ml.
Yeah, and the point is when you're talking about volumes, and I mentioned you get a big patient with a large knee, and your product, for instance, one of the commonly used products in the market is the ACP by Arthrex, and they produce perhaps like some smaller volumes, maybe 3 to 4 mLs, and you want more than that, so you just use another kit and not just. And for other kits, you can generate more, but then you dilute the concentration. You have lower concentrations, and you don't want that. You want to maintain the ratio. So you need to use either, depending on the knee size, a double, like 2 kits, or maybe use 2 kits, but just use like 1.5 of what you prepared. So it's just common sense. Yeah.
Yes, we know that for hyaluronic acid, for example, we can have some adverse reaction like a joint effusion. But did you experience that in PRP injection? And if yes, what would you think about the mechanism of production of this persistent joint effusion?
You want to answer? Yeah, so you're right. I don't see it quite often, to be honest. And I also think if you, it's funny, it's psychology. If you inform the patients properly, they'll probably not complain. You tell them that they might feel some sort of pain, some sort of reaction that it's common. And it usually goes away within either the first day or 2 or up to a week, and then usually it goes away. What causes it? Difficult to say. There are some studies showing that with leukocyte-rich PRP, you get more of these reactions, and that's probably one of the things that might be responsible. In my practice, as I mentioned, I use it quite often with hyaluronic acid, so perhaps this is also part of it. I also think that when we inject more than probably 5 mLs into the knee joint, they feel different, especially if it's a knee that didn't have any effusion in it. It feels strange, it feels different, and patients don't always know how to describe it, this uncomfortable feeling and so on. So the spectrum of what they can describe after the injection varies, and I try to talk to them about all these different sensations, and usually I get no complaints.
Yes, it happened, that's why I say, because it happened to me in one patient that was a colleague, a doctor, that immediately at 3-4 hours after injection, he developed a joint effusion. I aspirated, it was not blood, it was just the liquid. So, and I read some reports about immune response to this, so that may be. And effusion persisted for 2-3 months. So we didn't have any infection. We made cultures.
So
And then
I don't have a good enough explanation for it, whether sometimes it could be the injection technique. If you scrape the cartilage gently, that can cause this. I wouldn't expect like such an immediate response with effusion happening. So whether there was already a little bit of fusion and yeah, just irritating the cartilage a little bit. Radhika, maybe you have some.
Connected to our colleague question, in order to reduce this kind of complication in your daily practice, do you consider complementary measures after the injection, like ice, lower the level of activity? What is your opinion?
Yeah, this is what I ideally do in my clinic. In general, I don't believe in having a patient come in, you take their blood, you inject them, and then you send them out like within a few minutes. So you talk to the patient, you talk to them about the potential complications and this different scenarios of what they're going to feel afterwards. And I want them to sit in the clinic, and yeah, I usually have them put some ice or some device, and it often helps. Obviously, some injections are more painful. I also use it for the hip. It's a bit more demanding. I use it with ultrasound guidance, and I have all my patients sit, and I think it's very helpful. Yeah.
Yes. We have time for the last question, probably, if any.
It's connected with what you mentioned in the last words. So you consider also PRP in other joints. Do you modify the volume for a small joint like ankle? Do you save something from the volume?
Yeah. So for the hip is quite a large joint. And so in the hip, I usually use either the same or slightly larger volumes. For the ankle, definitely. And especially if you combine it with hyaluronic acid, it's not going to be able to take more than 4 or 5 mLs in total. So definitely I adjust it. Okay.
Yeah, so once more, thank you very much for giving us the possibility to share. We are definitely open if you want to reach out the ESSKA office or ourselves to get more information on the process, on the document. Again, you can download it from the ESSKA website under the section projects. It's not very intuitive where it's uploaded, but that's why I give you a hint. And hopefully we are coming up with 2 other consensus, the round 1 about the clinical scenarios of the ideal candidate for PRP, and the cell-based therapy, which we are now starting to work. Thank you. And unfortunately, I have to leave immediately, so I won't be able to stay for the next presentation, but I'm sure they will be very interesting. Hope to come back soon. Thank you.
Thank you.
Talking will be about the use of PRP in meniscal injury. And what do we know about the meniscus? It's not the place or the time to remember the meniscus function because they are well known already. But we should remember that meniscal pathology is very frequent. It's related to sports injury. It's usually, we deal with young and active patients, and it's grossly underestimated and undertreated. And another important issue is that the knee in which meniscal tear evolve, it's a knee that tend to have an accelerated cartilage wear, which will lead finally to the osteoarthritis. And also it is known that when we're dealing with already onset osteoarthritis of the knee, in over 70% of the cases, is a relation with a meniscal tear. We've been on the tremendous improvement about the treatment of the meniscal tear. We are no longer doing total meniscectomy, which was the fashion before years 1970, because we know that meniscus function are very important and we should aim for preserving the meniscus. But still, there is a large number of meniscectomy procedures done in the world all over. And how large is this number? You see, is a large variation between 70 up to 150 in 100,000 inhabitants. So it's already known that meniscal repair is the optimal surgical solution in case of a meniscal tear. We already proved that meniscal healing occurs, and the meniscal repair has started with vertical meniscal tear and now progress towards the radial meniscus tear repair, to horizontal cleavage, and even to complex degenerative tear. And we still face two entities in nowadays. One is that of arthroscopic partial meniscectomy. We thought when we first done this procedure that we are safe, or we are in a safer zone. And which are the clinical results told us? That after a partial arthroscopic meniscectomy is still a 7% cartilage wear every year. Above that, there are a high percentage of unfavorable outcomes. We're talking about 30% of the patients. And yet, this arthroscopic partial meniscectomy is still the most common arthroscopic procedure done all over the world. Despite of the fact that meniscal repair is a certitude and is the best alternative to meniscus tear. Why is that happen? We have very short-term results after meniscus suture, and they are great. The failure rate is about 10% of the cases. But when we move towards the long term, the failure rate increases up to 30% of the cases. And combining this with the reoperation rate, we end on a percentage about 20% of the cases which need a reoperation rate. So the answer why is still arthroscopic partial meniscectomy very frequently performed is based on this data. Could PRP help with meniscal tear? What is the action mechanism for the PRP? PRP is creating a scaffold for the self to migrate within. It supplies the injury sites with a large variety of growth factor. It promotes chemiotaxis, angiogenesis, collagen matrix synthesis, and cell proliferation. So it fulfills one of the imperatives for meniscal repair, which is growth factor. And also, it helped tremendously to the meniscal repair. So when can we consider biologic augmentation meniscal repair? The current data told us that PRP and bone marrow stimulation decrease the failure rates. So we should aim to a lower failure rates. Also, they told us that augmentation significantly improve the rates of meniscus healing, almost double the rates of meniscus healing. So why don't add the biologic augmentation to our meniscal repair? Another study tells us that arthroscopic meniscal repair augmented with PRP cut down the failure rate with 50% of the cases. And the study was done with activated PRP, calcium chloride activated PRP. So there is a place for PRP to be used in meniscal repair, especially when we're talking about the repair with poor healing potential. And here we talk about horizontal cleavage, we're talking about radial tear, but we're talking also about large and unstable bucket handle tear. Because if we have to think about what ways do we have to improve meniscal repairability, we have bone marrow stimulation, and you saw in the morning that is a simple surgical gest which improve our meniscus repairability. It can be done very easily. We can use trepanation, and also there are a lot of papers who prove the efficacy of the trepanation. It's mandatory to do rasping of the parasynovial with the parameniscal synovium, and we have a new alliate, which is the PRP. So it is proof by the literature that PRP in meniscus repair significantly improve the functional outcomes and also improve the failure risk. And which is very interesting also is that the same article proves us that this improvement, reduction in the failure risk is not encountered when we're talking about the meniscal repair done with concurrent ACL reconstruction, because that concurrent ACL reconstruction already provides in the knee the growth factor we need. Can be PRP used instead or with meniscal surgery? And when it would be beneficial? Whenever we address chronic tears, we might consider this. And this study is a study, double-blind randomized control study in which the authors applied percutaneous intrameniscal PRP injection with echo guidance for repair of symptomatic chronic meniscus lesion, and the improvement was very high, from 30% to 55% of the cases. And this proved that PRP together with percutaneous trepanation is highly effective in improving meniscal integrity. What about PRP in case of symptomatic degenerative meniscal tear? It's one of the tear which is a challenge for every arthroscopic surgeon. The PRP injected had proved to provide symptomatic relief and delay surgery. The number of injections was 4, the interval is 1 week, and the study published this year proved a short-term benefits. Can PRP be used concurrent with meniscal surgery? Yes, there are various types of pathology beside meniscal repair which can benefit for the PRP use. We pointed out this association between meniscal tear, degenerative meniscus tear, and meniscal cyst, in which PRP, not the liquid PRP, but this solid form, activated PRP was used as an autologous patch to reinforce the meniscocapsular junction, and the study proved that at 3 years follow-up was no recurrence of the cyst or of the meniscus tear. Can be PRP used after meniscus surgery? And if yes, which would be the reason? We are facing more and more patients which want to get back sooner to their level of activity, to their work site, and also we have some patients which are not satisfied with their arthroscopy surgery. So the PRP have been proved to effectively enhance the efficacy of arthroscopy repair, to reduce the failure rate for the repair, to reduce the severity of pain, and to improve active flexion. In other words, to improve the functional outcome. Can be PRP used instead of meniscal surgery? And we're talking here about the intrameniscal tear, those tears which are not complete, and in cases of very active and young patients, it has been proved that intrasubstance meniscal tear can be treated with PRP injections, and the achievement is pain relief together with halt of MRI tear progression. And this study recommended 3 injections, 1 per week, and has in the background of the study the MRI proving that the tear did not progress over this treatment. Does the number of injection count? The reported data in the literature suggest to use 4 up to 6 injections when we trying to augment the repair, and to use 4 injections at 1 week interval if we try to do a biological repair on meniscal tear without surgery. So finally, when do I use PRP and meniscal surgery? As a parenthesis, we're using PRP in Colentina for about 7 years. We start to improve our technique and to make a more careful selection of the cases. And more recently, we use it in isolated meniscal repair whenever this repair is not done with a concurrent ACL reconstruction. We use it with the tears which prove to have poor healing potential as radial horizontal cleavage or large and unstable bucket handle tear. We use it after total or partial meniscectomy. Why? Because we want to improve the quality of life for our patient and the functional outcome. And whenever our patients prove to have concurrent cartilage lesion. Thank you.
Thank you for the presentation. I will present the next topic about the use of orthobiologics in ligament injuries. So, as many of you know, we have sometimes problem with the results of our ligamentous surgery. There is a lot of controversy still about the treatment of ligamentous injuries. The incorporation of the tendinous graft and the restoration of ligamentous stability is sometimes slow, and this may be due to the hypocellular and hypovascular nature of the tissue. Moreover, the structure and the function of the repair tissue remains inferior to the uninjured ligament. Let's talk a little about the vascular supply of the knee ligaments. The ACL blood supply derives from an arterial plexus, which anastomoses the branches from the middle genicular artery and the infrapatellar fat pad. Actually, it's a poor vascularization of the ACL, as we all know, and this plays an important role in the healing of this ligament. On the other side, we have the MCL, which has a good vascularization, which explains the increased potential for healing of this ligament. And the blood supply of the MCL is derived from the medial superior and the medial inferior genicular arteries. That is why, because the MCL has multiple blood vessels branching throughout the epiligament, with many of these vessels penetrating into the substance of the ligament, we have a good healing. On the other side, we have the ACL with a poor blood supply, limited to 1 or 2 branches from the middle genicular artery, which doesn't provide a good vascular supply for supporting the healing of the ligament. The ACL has, as you know, a negligible repair response to injuries, whereas the MCL heals very well without, in many cases, the need of repair. There are, however, multiple factors that influence knee ligament injury and repair, like the location of the injury, the size of the injury, the blood supply, or the location intra or extrasynovial. And we can see here that the healing of the intra-articular ligament ligaments in case of knee injuries is less reliable when compared to the healing of the ligaments located outside the joint. This is due to the presence of the circulating plasmin at the level of the joint space, which breaks down the fibrin clot, determining a suboptimal clot formation. Moreover, the synovial fluid inhibits ACL fibroblast proliferation and migration, thus retarding the healing of the ligamentous tissue. Now let's talk a little about the ACL repair. This technique was popularized initially in the 1950s, and the long-term results of the studies from that period were poor, with more than 90% of failures. So at that moment, the technique was abandoned. However, the recent publications demonstrated the possibility of ACL healing after primary suture of the ligament when an augmentation with growth factors or mesenchymal stem cells is used. And we have this study published in 2013 by Gobi, which demonstrated that 98% of the patients with partial ACL tears, but it was a very strict selection of the patients, we should bear in mind that, had good final follow-up results regarding the IKDC objective score, the Tegner score, as compared to the pre-injury levels, and more important, the re-rupture rate in this case serious was only 8%. So ACL repair may represent a solution, taking into consideration these latest studies, and also considering the potential advantages of ACL repair over ACL reconstruction, because it allows the preservation of ACL anatomy, kinematics, and proprioception. It is associated with the absence of donor side morbidity, and we have reduced postoperative muscular weakness as compared to the reconstruction techniques. And now, which are the biologic we have the biologic augmentation options for the healing of the ligament, and optimizing the healing conditions using this biological supplementation may lead to improved quality of the repair tissue. And the latest laboratory and even some clinical studies are promising regarding the use of orthobiologics for treating ligament injuries. However, still the literature is inconsistent, and we still have to wait for new studies to support their use. The biologics may provide an alternative to surgical procedure when non-operative treatment is preferred, or they may be used in addition to the surgical intervention due to their potential to improve graft integrity and vascularity. And what are the options? The options we have the growth factors, we have the cellular orthobiologics like the mesenchymal stem cells, and we have the newly used scaffolds or cell scaffold composites. The growth factors, you know very well that after an injury, the platelets travel to the wound site, forming a clot in order to obtain hemostasis. At the level of the wound, the platelets secrete peptides such as PDGF or TGF-beta, which have an important role in the initiation of the repair processes after the injury. These factors released by the platelets have a chemotactic effect for the inflammatory cells and are in charge for regulating the proliferation and differentiation of the fibroblasts. The inflammatory cells release other peptides such as FGF, EGF or VEGF, which have very important stimulatory effects on the ligament healing. However, it is very well known the hostile environment of the synovial joint space, as we were discussing earlier. During ACL injury, the synovial membrane is torn, which exposes the ligament ends to the synovial fluid and the potential destructive enzymes released by the intra-articular bleeding. And also it's a hostile environment because the synovial fluid washes the clots which tend to form at the ligament injury site, creating thus a deficiency of growth factors for the healing process. The administration of PRP may enhance collagen remodeling and induce hypercellularity, which may contribute to improve the healing process. And it is important to know that without the necessary stimulus from the growth factors, the response to injury is in many cases poor. And now let's take a look about what we can find in literature about growth factors. We have a study which demonstrated the significant improvement of biomechanical and histological properties of the injured ACLs in a rabbit model when it was used TGF for the treatment. We also have another treatment, another study which demonstrates the effects of the VEGF in improving the vascularization and fibroblast infiltration of the graft. However, the same study demonstrated that the VEGF injected ships had an increased graft laxity at 12 weeks. We have other studies as well, and we have this study published by Murray, which demonstrates that ACL repair, there was no beneficial effect on ACL repair when using PRP, but the explanation for this may be that the fibrin clot may have been prematurely dissolved by the intra-articular environment. And in another study, Cheng tried to find a solution to that problem, and they tried to use scaffolds in order to protect the graft from early degeneration. And this time, the use of PRP associated to a collagen hydrogel resulted in improved results concerning the cellular activity and the collagen production. There are some clinical studies as well which demonstrate the improved results of when using the PRP for treating ACL lesions, whether before reconstruction or after the reconstructions. And now let's take a look at the advantages of using the cellular orthobiologics. You can see on the slide that the growth curves of ACL and MCL cultures showed a significant slower rate of proliferation for the ACL when compared to the MCL cells, which supports the lower proliferation and migration potential of the ACL cells. We may use the mesenchymal stem cells as a source of precursor cells to enhance ligamentous healing, but it's very important to mention here that anatomic apposition of the torn ligament fibers is essential because in most of the cases gapping between the fascicles prevents cell migration and tissue regeneration. We have also some studies some publications in the literature, but this time mainly basic science studies, which are also encouraging about using the cellular orthobiologics. And now we pass to the possibility of using scaffolds or cell scaffolds composite, which may offer a very interesting therapeutic option for augmenting the ligamentous repair by accelerating the ligamentous healing and ensuring an enhancement of ACL cell viability and collagen synthesis after using this kind of products. In this situation, the PRP and in the situation of cell scaffold composites, the PRP and the MACs will act as a source of growth factor and precursor cells, while the scaffold acts as a matrix in the cellular process and even as a biomechanical support for the primary repair of the ACL. So, when speaking about orthobiologics for ligamentous lesions, it is very important to bear in mind that optimizing the healing conditions by using this kind of biologic supplementation may obviously lead to repair tissue of superior quality. Biologics have been shown to have very good results in improving tissue regeneration in laboratory studies. However, we still have to obtain more results from the clinical practice. Thank you very much.
Dunlop to you to make his speech about orthobiologics in tendon injury.
Thank you very much for the kind invitation. will present. It's okay? Put the presentation. So I have no disclosures related to this presentation, but I have a very early, like 2008, orthobiology contact, and they entered my personal practice, and most of the things I will present here are also from my personal point of view. There's a large literature regarding this topic, tendinopathy, and I invite you to search, and you'll find an impressive and an immersive literature in the last 10 years. It's actually a very confusing term. It's a continuum of disease. There are multiple pathologies in the same generic terms. You can find it, and you will find it in your current practices. And mine, as much as 30% of the patients will have musculoskeletal complaints about a kind of tendinopathy. Tendinopathy is defined with a pathology with tendon pain more than 6 weeks old, and what is important, the non-inflammatory process is linked with the neovascularization and neoinnervation. There are issues that need to be discussed, and they have a point here in our presentation. There are a lot of conditions. Not all the tendons are the same. You'll find it in the upper extremity, lower extremity, and you have to be a very good doctor. You have experience, and when deciding the treatment protocol, you have to take a lot of these factors in the discussion. As always, I will recommend my patients with tendinopathy what is in the literature, and in my experience, the almost 12 weeks of kinetic training, eccentric strengthening, progressive loading. There's a lot of involvement with my colleagues from rehabilitation issues, and this is the first line of treatment. And then what happens when this first line of management fails? We as surgeons try to inject. There is a history for steroid, but it's recommended, and I will show you some papers only in non-weight bearing. And I'm showing you because at the beginning I didn't put it here, a presentation involving orthobiologics, which was not only what you've heard here about cellular therapies, but also hyaluronic acid and corticosteroids. They were all therapies, orthobiology therapies with certain effects. Now we'll talk only about cellular therapies in here. There are papers, and I mentioned in this kind of tendinopathy about high volume injections, and Professor Mafuli visited Romania, and we discussed this kind of treatments. And also we discussed a lot about the moment and the way we treat the patients. It's very important to think about the chronic, because the chronic degenerative tendinopathy requires some kind of mobilization of the scar tissue. So orthobiologics may work, but you have to be careful how do you use it, you know. And the development of understanding the field of tendinopathy developed in this last 10 years related with the orthobiologics in parallel, because not only the 1 to 2 years for the tendon to heal, but about the growth factor, about the evidence, the preclinical evidence that this is a very important point. We can regenerate tendons, and there were preclinical studies more than 10 years ago. Also, the field improved more information about the timing of the patient. You know, it's an issue, and I will discuss it. The moment to use the PRP a little bit, and how we can influence, how can use supplements. And there's a lot of hype now on the internet about these proteins, the addition of supplements. You may find metformin and some discussion in the same orthobiologic issues. So another point, second point, but I discussed it earlier, is very important to ameliorate your technical procedure. You know, this is the emergence of musculoskeletal ultrasound, and in the last 10 years, we got better results due to use of ultrasound. When we take a look at the clinical outcomes, the literature lacks a little bit. It's promising, but still under investigation. You see, I think it's about 10% of the literature related to the tendinopathy. And of course, there's no discussion, and this is one of the take-home messages, numerous studies that show the need for alternatives in the pathology of tendinopathy. You know, avoid corticosteroids here. And we'll start with the pros. And they are beginning to appear this kind of randomized control study, RCTs, with level 1 evidence for several pathologies. And my personal experience is with lateral epicondylitis and patellar tendonitis. These are the main indication with pros. And you'll see that okay, the lateral epicondylitis, the majority of research and actually much of the PRP treatment in tendinopathies was pushed by the very good results in the lateral epicondylitis and the medial epicondylitis. But when we took another step to use it in the rotator cuff pathology, the results weren't the same. Similarly, we get good results in the literature and in the clinical studies for the patellar tendinopathy, but not so good results in the Achilles tendinopathy. Not much of a clinical, and I mention again, these are very good randomized studies, and they all have a very good approach with kinesiotherapy and all that, the treatment according to the plan. One issue may be related, as I mentioned earlier, it's not the substance, but actually the technique, how we use the technique in our infiltrations. And this is why I do the epicondylitis and the patellar tendonitis injections because they are more painful. And the rest of the injections that need more ultrasound guidance, I send them to a friend of mine, which is sports medicine doctor, let's say for the shoulder or for the Achilles tendon or other indications. And we know that, and Stefan Mogos mentioned earlier about the results in the knee. It's similar in the shoulder because when you inject it, it dilutes, and there's not so much of an effect of the PRP in the tendinopathy related to surgery. So these are the conclusions related to this blood product, the PRP, the product. So I'm a devil's advocate here, and there is not sufficient evidence for use the PRP in tendinopathy. There's no still a standard of treatment. There are results, I've told you, in the treatment of epicondylar and in the knee. And there is an idea of use it with hyaluronic acid with better results. So alternatives were requested, and there is a raise and a very important preclinical evidence for the use of these mesenchymal stem cells, the cellular therapies. First line of treatment with mesenchymal stem cells that was available even in our country was related to bone marrow concentrate with early promises for this pathologies, and you can see it, early small series, but with early promising results. Not all the products here are equal. There is an important variability also in this specialized product, and most of them are used in complex therapeutic scenarios. Remember, you do a little surgery and you use the cells, or you do injection therapy and you use also cells and PRP and mesenchyma, they are complex scenarios in development here. But the rising star here in, I'm talking about tendon pathology, are the cellular treatments from adipose tissue derivatives, because they are easier to perform, easier to, and they have surprisingly concentrated results in the concentration of mesenchymal stem cells. And here the literature, yes, there are no optimum protocols, but the literature is, I think, a little more promising than the mesenchymal, the bone marrow concentrates. In summary, what we can do, we have to follow the protocol with physical therapy, gymnastic, and then we use our injection therapies. It still need of you still think of biology, but you still need to know your patients and use these orthobiologic procedures in a good manner. Thank you very much.
Thank you for this talk. I will introduce the next speaker, Horea Bena, who will present the topic about the orthobiologics in cartilage injuries.
Okay, thank you very much. Good to see you again here. And I will talk today about cartilage injuries, no conflicts of interest. So, why are nowadays cartilage lesions treatment is a domain of high focus? And why? Because we haven't yet obtained a perfect healing, like a perfect restoration of hyaline cartilage. So why is this issue? Because left untreated, the lesions can progress to osteoarthritis. Why does not the cartilage heal? Because it is hypocellular, it's non-vascularized, and it doesn't have lymphatic vessels or innervation. So in my mind, orthobiologics are just common sense to bring what cartilage needs: cells and growth factors. I will not insist on the anatomy and of the cartilage, as we all know and we have passed through it. It's important to divide the cartilage defects in focal cartilage lesions caused by trauma, by degenerative changes, or iatrogenic maybe, and degenerative complex cartilage, not only focal lesions. The clinical symptomatology is classic with pain, pain at activity, pain at rest, and the indication for treatment is in the case of focal lesions, the grade 3 and 4 by outer bridge classification. Of course, MRI is the best tool we have to identify these lesions. For me, orthobiological, and for me and for everybody, orthobiological treatment does not mean only PRP. Apart from PRP, we have the bone marrow aspirates, the adipose-derived mesenchymal stem cells, or the addition of micronized autologous or allogenic cartilage, and also the tissue-engineered strategies. This is mainly used for focal lesions, and for osteoarthritis, we also have the hyaluronic acids beside PRP, the bone marrow aspirate, and the adipose-derived stem cells. What we were taught and what we teach our students is, for example, in healing of the bone fracture, is to preserve the hematoma. No? Why? Because it has the factors there. In cartilage lesions, we don't have a hematoma, so we must bring something there to enhance the healing. There are lots of studies concerning the use of PRP in cartilage treatment, and there are studies that report satisfactory outcomes at the clinical level, at the preclinical level, but there are also some that do not depict any enhancement of the healing or of the clinical function after utilization of plasma, of platelet concentrated plasma, either general instilled in the joint or local use of it. The bone marrow aspirate concentrate is another promising star, and me personally, I'm waiting for the next ESSKA Congress in order to hear about the new guideline from ESSKA concerning the cells in orthobiological treatment. So there are studies comparing to PRP, there are studies comparing it to hyaluronic acid, and they show all better results. And this is not only due to the differentiation of the stem cells towards cartilaginous lineage, but also because of the constant secretion of growth factors. So they act like reservoirs of growth factors that act locally for paracrine effect of the growth factors. Another promise is the autologous adipose-derived stem cells preparates that may be either from the stromal vascular fraction or either from the micronized preparation of the adipose tissue with mechanical mean without laboratory processing, and they may seem to have good promises and good results applied in local cartilage defects, also in extensive cartilage defects, especially in osteoarthritis. ESSKA supplementation, hyaluronic acid with different formulation, different concentrations, they seem to work, and it was very nice presented in the Orbit consensus that may be less good effect than the PRP. But there are clinical studies that show the good amelioration of scores and of the clinical function, especially in the knees. Combination of platelet-rich plasma and hyaluronic acid, it works. Very good results reported on the literature. Comparing, there are trials that also most of them present better results for PRP, but there are also some studies that present better results for hyaluronic acid alone. So it is to be cleared in the future what would seem to work better, but I guess the combination of the two will work. We have to take into consideration other sources of cells for cartilage repair, like MSCs proving that may be collected from circulating blood, the umbilical cord tissue, or synovial membrane. Also, there are techniques that use differentiated chondrocytes, micrografts, obtained from the nasal or auricular cartilage, and there are already studies that show good results in terms of healing of the cartilage. Next thing to focus for cartilage, for focal defects, is the tissue engineered strategies that combine the scaffolds, usually membranes or constructs based of collagen fibers, hyaluronic acid fibers, together with the biological products, like the ACI, the first to be used, the MACI, the addition of chondrocytes on this scaffolds, and also which are reported to work very well with restoration of cartilage, of hyaline cartilage, but they have to be proven, and it's not so widely available due to regulation of implantation of these cartilaginous cells. And for us as surgeons, we are trying to develop strategies that can act in a single step intervention and not to perform two interventions in the same patient. Another strategy implies the hydrogels, the addition of carriers for these orthobiological products and they seem to work especially in diffuse cartilage destruction as it happens in osteoarthritis. So different carriers, hyaluronic acid, collagen dilution in a solution, and new results, they report very good results with this use of hydrogels as carriers. The scaffolds, there are different commercial available scaffolds, and I am sure that there are also in production new types of scaffolds to help as a mechanical support for the biological environment provided by these orthobiologic products. There are studies that report good outcomes of the collagen scaffolds in preclinical setting, that means in animal experience, and also in the clinical setting. So, what's the next step is to demonstrate the results. So we research. We also here are doing studies on orthobiologics. So in this order, we have done preclinical studies on animal model. This is rabbit knee that we have performed cartilage focal defect that we used for reparation, collagen membrane impregnated with cells obtained in a group of rabbits from the adipose tissue that was laboratory treated to extract the mesenchymal stem cells, and in another group we have used the lipoaspirate fluid, which is a part of the substance obtained from centrifugation with a special kit of this adipose tissue obtained by mechanical procedure, and it seemed that the group treated with these latter cells and growth factors from the lipoaspirate fluid performed better in terms of restoration of cartilage. Also, we have performed studies on sheep doing comparison between the mesenchymal stem cells obtained from bone marrow aspirate and the cells obtained by from the stromal vascular fraction of the adipose tissue. In this case, the group with the cells obtained from the medullary aspirate seem to perform better in terms of regeneration. Also, we are passing now to, we are moving on.
Sorry to interrupt.
I will finish immediately, okay? No. So we will pass on to treatment by orthobiologic factors with a carrier, with a biogel carrier on an osteoarthritis model in rapid knee. We have translated also this in clinical practice for restoration of post-traumatic cartilage defects or for degenerative changes of the cartilage. We are currently using 3-laminated membrane in which we add concentrated stem cells obtained from bone marrow aspirate, but also from the lipoaspirate, with very good results, as we can see. Also, we are doing injection of bone marrow concentrates with good results, even in radiological aspect changes with thickening of the cartilage. So in conclusion, orthobiologic represents a good and modern treatment for osteoarthritis and for cartilage defects, and we have to take into consideration the use of these orthobiologic products together with scaffolds and membrane or carriers for diffuse articular lesions. Thank you very much.
Thank you. Unfortunately, we are very close to the end of this session. I think we have time for one or two questions from the audience. I think if there are no questions, we can... Sorry. Do you have a question? Thank you for being here. We will end this section about orthobiologics. Bye-bye.
Thank you for
Thank you for being here.